we find that we prefer to use single-agent therapy just as a general rule in medicine, I believe. However, there are patients who cannot tolerate interferon. Certainly, that's in the order of 15 to 25%, depending upon the experience of the investigator. And that's also using older forms of interferon, not the row-peg interferon that I mentioned has been approved now by, of course, the European Medicines Agency and the Food and Drug in Europe and the Food and Drug Administration in the United States. So we now have these commercially available drugs. Unfortunately, many physicians still use hydroxyurea and phlebotomy only in the United States. So we have an education issue as well. We have to educate the doctor as well as the patient. So far, these drugs, interferon and hydroxyurea, are very effective. But as I said, they do have toxicity, and some patients cannot tolerate them. Professor Hasselbalch was the first to show that if you combine interferon, an older form of interferon, Pegasus, with ruxolitinib, that you can increase the tolerance of the interferon. So that combination therapy with an anti-inflammatory drug such as ruxolitinib may increase the tolerance of the drug for the patient. The goal of treatment is not to have the patient develop significant myelofibrosis or end-stage disease. And unfortunately, 5 to 10% of patients with polycythemia vera do terminate in acute leukemia. I think the treatment of that form of disease is very unsuccessful, even today, and I don't want to take the time to discuss that treatment. But there are new forms of treatment for patients with myelofibrosis that had been developed for the treatment of patients who first had idiopathic myelofibrosis. That's a related myeloproliferative neoplasm, and is very similar to patients who develop post-polycythemic myelofibrosis. That occurs in about 20 to 30% of patients, but eventually, if they live long enough, most patients will develop myelofibrosis. But however, we feel that if you use interferon early, you may not develop myelofibrosis at all. So whether these new treatments that are going to be used in idiopathic myelofibrosis will ever be employed in post-polycythemic myelofibrosis remains to be determined, because the success rate with interferons is so high. And the other thing is that we have difficulty in evaluating drug responses, because fortunately the myeloproliferative disease, polycythemia vera, and essential thrombocythemia are long-lived illnesses. Our median survival in our institution is now beyond 24 years. So, and that's been seen in other institutions in Europe as well. So that to evaluate a drug treatment is going to require lots of time, lots of generations of hematologists, unless we find a surrogate marker, much like the Philadelphia chromosome in chronic myeloid leukemia. We know we don't have to follow patients, fortunately, to their untimely death, because if their Philadelphia chromosome is not, the number of Philadelphia chromosomes in the marrow are not ameliorated or improved, we know that patient is not going to do well. So therefore, we have a wonderful marker cytogenetically, and there's a wonderful molecular marker, BCR-ABL, which correlates very, very magnificently with the Philadelphia chromosome and, of course, clinical events. There's an argument whether the major molecular abnormality JAK2 V617F in polycythemia truly correlates with the clinical course of the disease. For example, it's been found by us and our Italian colleagues, Professor Venucci in Florence, that in general, that if you have a high JAK2 level, those patients tend to do worse. tend to have more progressive and advanced disease, or more aggressive disease, but it doesn't always follow. It's not one-to-one. And we have found, for example, patients who are in good clinical remission still have a high JAK level. When you do a bone marrow biopsy, you find they still have a very hypercellular marrow, yet they're doing very well clinically, and they're in clinical and hematologic peripheral remission, even though their bone marrow is still, quote, sick and consistent with polycythemia vera. And those patients often have still a very high JAK level. So that correlation that we see in CML has not been the same, in our opinion, in PV. We're still looking for good biologic markers. We have leads. There's so-called fitness, which our institution, under the lead of Joseph Scandura, has been developing, but it's a very tedious laboratory procedure, and we're looking for alternative methods to develop a marker which will tell which patient is going to do well and which patient's not.